ultrasound of the aorta in the critically ill patient. A few points before we move forward about didactic lectures. Remember, hands-on instruction is better explained in the bedside videos portion of the curriculum. Reading material is also important to cover aspects that are not discussed in this lecture portion. It's also very important to mix hands-on active learning with the reading and didactic material to best learn each of the ultrasound applications. And so the curriculum is set to incorporate active learning throughout the didactic portions. First, just like any other ultrasound application, we must talk about our focused questions. One question is, what is the size? The normal size for abdomen aorta is less than 3 centimeters, and the normal size for the iliacs are less than 1.5 centimeters. So if you have greater than 3 centimeters or greater than 1.5 centimeters in the iliacs, you have abdominal or iliac aneurysms. If you have hypotension, you must consider a rupture of the aorta as a cause in these patients. The second question is less important, but it's also something we ask ourselves, is the aorta patent? The type of probe we're going to use is either the abdominal probe or the cardiac probe. The preference is for the abdomen probe because the footprint is larger and easier to visualize the structures. Here you see a normal image that you would see if you place the probe in transverse orientation on the top left. The main structure you should identify is the vertebral body, the aorta, and the inferior vena cava. As I will show you in the next slide, it's important to note the relationship of the aorta and the inferior vena cava. The aorta is to the anatomical left of the inferior vena cava. Usually, the aorta is sitting right on top of the vertebral body, the vertebral spinal shadow. On the bottom left, you see a longitudinal view of the aorta. In this view, you can also see some of the branches, such as the SMA and the celiac artery. As you see in this clip, you start with the aorta and then fan to see the IVC, fanning the probe to the patient's anatomical right to view the inferior vena cava. This is very important to make sure that the inferior vena cava and the aorta are appropriately found. It is very easy to confuse both of these if you are not careful. A few other points is the inferior vena cava has liver visible on both sides of its borders in the long view, whereas the aorta does not. Another thing is that the longitudinal view of the aorta is important to find, but for measurement purposes, we would rather have the short axis view. As you can see on the top left, if you use longitudinal imaging, the true diameter of the lumen can be misdiagnosed. If you cut the plane not in the center of the longitudinal view, you can severely underestimate the size of the aorta. Here is a short axis view of the abdominal aorta. You can see the spinal shadow and the markings for the thoracic abdominal aorta. In this particular view, it's 1.45 and 1.52 centimeters, or definitely less than 3 centimeters. And remember, you are to measure from outer wall to outer wall. In future slides, I will show you images where this can be miscalculated. As you go further down, you actually can see the distal aorta split into the two iliacs, as you see on the top left. As you split, you can also measure these, and you can see in the measurements below, these are all below or less than 1.5 centimeters. Another common problem when trying to obtain the aorta view is bowel gas. As you can see on the left, a lot of times the view that you're using, bowel gas can come in the way. One way to alleviate this is to use slow and steady pressure, as though this will move the bowels out of the way, or try to obtain the view from a little bit of an angle, either left or right, from where you are. So let's talk a little bit about aortic aneurysm and dissections. Some cases present with shock as the only finding. Traditionally, we talk about pulsatile mass as the fastest way, but the sensitivity and specificity for these are poor. Ultrasound provides a rapid, accurate, non-invasive, inexpensive, and reproducible way to identify aortic aneurysms. You might ask yourself, can I do this? Well, there have been many articles showing that there is good agreement between measurements of emergency physicians made and by CT by radiology staff. These studies are from 2000-2007, but there are more recent studies that confirm this. So in discussion of important points, remember that you must obtain these images from the epigastrium all the way to the iliac bifurcation. It's a circular vessel immediately anterior to the vertebral body. Left of the paired IVC, remember to get the IVC and aorta relationship. Remember to measure outer wall to outer wall in the short and long axis, although the short axis is preferred. Greater than 3 centimeters is abnormal in the abdominal aortic thoracic area, and greater than 1.5 centimeters is abnormal in the iliac area. Thrombus and ruptures are harder to visualize, but I'll show you a few of those also. So here you see a large 8.8 by 8.6 aneurysm. You can actually see a flap and a false lumen, although this is not always visualized. Here's a picture of correct outer wall to outer wall measurement. The dark black line is the actual wall. The white lines are what you may accidentally measure if you were not looking exactly at it. Here comes the yellow lines that show probably the more accurate wall measurements. Here's a thing called onion ring artifact, where several layers of calcifications make it look like that the aorta is smaller than it really is. If you were to just measure the lumen, you may falsely identify this as a normal aortic size, but you can see it's actually a lot larger. So remember, what's important is the entire course evaluation. Infrarenal are the most common aneurysms, and if you just measure the thoracic abdominal aorta, you may miss most of these. Retroperitoneal bleeding is not visualized well on ultrasound. Slow and steady pressure can help with the bowel gas. Contrast enhanced may help. There's these new studies using microbubbles, but we do not have that available at the bedside. And remember, if you diagnose a AAA and the patient is hypotensive, you must consider that rupture is part of your differential diagnosis and have a plan ready. Remember, evaluation for dissection has poor sensitivities. The aortic root dilation and aortic intimal flap can help diagnose, but are hard to also find. In the peristernal long axis view, the aortic root greater than 3.8 centimeters is abnormal. The suprasternal view placed in the suprasternal notch, aimed caudally and anteriorly, can help also find these, but it can be very difficult. And color flow can also help look for intimal flaps. So remember, the final slide, back to our focus questions. What is the size of the aorta? In the abdomen, less than 3 centimeters is normal, greater than 3 centimeters is abnormal. In the iliacs, less than 1.5 centimeters is normal, greater than 1.5 centimeters is abnormal, and is a patent.